Okay, good afternoon, everyone. My name is David Parsons from the Children's Hospital and the University of Adelaide. I'm standing in today at late notice for Jenny Cooper, who finds herself somewhere in a large plane over water somewhere, heading off to the other side of the world. This is the WCHN Paediatric Immune and Metabolic Disorders section of the ABMC Research Mini-Reviews. For today, if you have any questions from the speakers today, can you type in the Q&A section at the bottom of your screen, please? I acknowledge here the traditional custodians of this land and pay my respects to their elders past, present and emerging. This session is being recorded and will be available on the ABMC website. I also see there's at least a number of them on YouTube already. So the first speaker today is Tony Ferrante. Professor Antonio Ferrante, sorry. He'll be speaking on newborn screening for allergy risk and early intervention to prevent allergy. So I'll hand this over to you now, Tony.
Thank you very much, David, and welcome all the audience to my talk, and thank you very much to the organisers for inviting me to tell you something about the research that we've been doing in the last 15 years. And I'll begin with my first slide.
So if you go into share screen, Tony.
Yep.
Yeah.
Does it come up? It's come up now.
And go to full screen in PowerPoint. Lovely.
Okay, thank you very much. And this research is about tackling what we consider to be an important question in allergy, and it's more to deal with trying to prevent the risk of developing this disease. And I'd like to begin first of all by perhaps going back 50 years ago when I had to present my current paper to Professor Derek Roll in Department of Microbiology to really prove that there was a thing called IgE, which was then also considered to be a mediator of the reagenic and allergy reaction. And this was a discovery a few years before I presented this paper by the Ishizaka husbands and wives, where they proved that there was another antibody. We had got up to IgD and now we had progressed this to IgE. However, it suffices for me to say that as quoted in this article by Susan Prescott and Mimi Tang and published by Askia, that although it's now just over 50 years, 55 years since the discovery of IgE, we really now still have a major challenge. We really haven't overcome the issues regarding allergy, where we consider now about 40% of Australian children have evidence of allergic sensitization, and many of these will go on to develop allergic diseases. And some of these will persist, these individuals will persist into adulthood. And so it seems to me and to many that strategies that reduce the risk or severity of the disease could have enormous impact on the community. With this in mind, we developed these goals, and that was one, to develop a newborn screening test for the risk of allergy development. So as you see in this slide, that upon birth that you predominantly have an immature T helper cell cytokine phenotype, which may then continue in that form of T helper 2, and this means that then you are prone to developing allergy. At the same time, we were also interested that this might be an opportune time to be able to redirect the immune system so that you may have a balance and perhaps away from developing allergy, which was their second goal in this research. Now, the story of our research group really comes earlier on, where we were looking at the physiological immunodeficiency of immaturity in the neonate. And we were interested in the basics of this lack of immune responses in neonatal T cells. And while investigating these, we had experience in intracellular signaling. And one of the families that we looked at was the protein kinase C. And what was interesting during this development was that we found that that cord blood, or sort of early in the neonatal period, that these protein kinase Cs were not being expressed to the level that they were in adults. And you can see one that we're interested in is PKC zeta, is actually a very low expression and then increases by 28 days following birth. And then it more or less maintains itself to actually adult levels at this stage. So we became intrigued by this, and what I think struck me is that when you looked at not every baby born had this deficiency in PKC zeta, and it was at around about 40%, which really equated close to the incidence of allergy in the community. And so then we began a collaboration with Professor Susan Prescott, and this was really a retrospective study now, because they had already followed children after birth over a period of 5 years. And so they had already clinical data, what was happening to these children. But what they did was to cryopreserve the PBMCs and the T cells from these babies, and we were able to go back and look at the relationship between the PKC zeta levels and the development of allergic diseases in these babies. And we looked at compared it to 1 year and also to 2.5 years old, but the results were very, very similar. And what you'll see from this graph, and I won't go through all of it, but you can see right at the beginning when we looked at those diagnosed with allergy, that they had much lower levels of PKC zeta than the other group that did not develop allergy at this time. And I think what was interesting is that we also looked at the other PKC isozymes, and only PKC zeta correlated with the development of allergy, so the levels of this particular isozyme. And looking at predictive values using the receiver operating characteristics, we were able to come up with a figure of 62.3 value. And if you were less than this value, then you had a sort of a greater chance of developing allergy. And the testing would give you a sensitivity of 80%, specificity of 63%, and accuracy of 71%. Now, this was far more, according to Susan, who's experienced in this, was much better than other biological markers, including cytokines, and more sensitive than the family history. So we proceeded then to look at this in greater detail. So we went to the time that the baby was born and looked at cord blood T cells. And what we really found here, using this surrogate sort of model of T cell development in culture, which goes over a period of 7 to 8 days, where these T cells mature from immature cells. And what we found was that the PKC zeta within sort of a day started to dramatically rise following exposure to maturation agents. So eventually the T cells, irrespective whether they had a low or high PKC zeta, the low ones also had normal levels to be able to have normal signaling at that particular stage. So this again intrigued us. You could find a CD4 positive T cells, CD8 positive T cells, and you can see there's quite a dramatic increase over this period of time. So then we went in and really asked the question, you know, can we find compelling evidence that PKC zeta plays a major role in this development towards a T helper 1 cytokine phenotype, as we had seen before? And of course, we looked at the levels of PKC zeta and looked at the cells after they had developed over the 7-day period to look at the cytokine pattern. And here we see that when the PKC zeta is high, then they're developing towards a T helper 1, compared with the low, which are developing towards an IL-4 producing cells and T helper 2, sort of allergy promoting cytokine phenotype. And in a second type of study, we actually knocked down PKC zeta from cells that had normal levels of PKC zeta. They would be sort of T helper 1s. And as you can see here, there's more TNF being produced than IL-13. And as soon as you knock down the PKC zeta, you see that it's completely converted the other way, where the cells are developing towards T helper 2. Furthermore, you ask the question, I mean, this is protein, but do you need the activation of PKC zeta? So what we did was we developed another model where you would stimulate to mature the cells, but in this case, PKC zeta was not activated because using PMA does not activate PKC zeta. And we can see that there is not much interferon gamma produced, but this is increased as soon as we transfect the T cells, nuclear infection of these cord blood T cells with PKC active plasmid, so an active PKC into these cells, then suddenly the interferon gamma goes up, and so we are moving the cells towards a T helper 1. So you need the protein there, and of course the activation. And so we think
about a minute left.
Sorry,
Tony, you've got about a minute left.
Okay. The second aspect of it was to see that when we, in the clinical trials, some of the women were given supplementary during pregnancy of omega-3s, and we found that this would increase the levels of the fish oil, omega-3s would increase the level of PKC zeta, but not of the other PKC isozyme. And further studies suggested that this was an epigenetic regulation by the fish oil. Now we've gone further, and our studies have suggested here that this ratio of omega-3s to omega-6 is very, very important. And when we subject ourselves to omega-3s with like DHA here, we see PKC goes up, and we now see that you get predominantly a T helper 1 phenotype in the T cells been developed over 7 days. When you use omega-6, you get completely the other picture, the other way, that is they go towards a T helper 2. And therefore we think that this is an important balance and intervention that you could use in this window of opportunity early on. And sort of towards the last part of my talk, I'd just like to say that we're getting into the complications of the mechanism, what's going on. And I've just looked at DHA here, but it also works with arachidonic acid. But with DHA, what the evidence is suggesting that it is metabolized through the lipoxygenase pathway by this data, and that when you form this resolvin D1, it seems to be the predominant metabolic product that's giving rise to this increase in PKC zeta. And of course, when you use arachidonic acid or the omega-3s, they actually induce PPAR gamma, peroxisomatoproliferate activating receptor gamma, and that leads to a decrease in PKC zeta, and hence arachidonic acid pushing the responses towards a T helper 2. So just in summary, where we're up to, we feel that we have now evidence that PKC regulates the neonatal T cell developments towards a mature T helper 1 cytokine phenotype, that the protein could be used as a pathology test to identify babies that risk the development of allergic sensitization. But of course, this is not good enough, because there is no point in identifying them without having some sort of I guess, intervention. And we now present some evidence, early evidence, that there's a window of opportunity after birth in which intervention can be applied to alter the PKC zeta levels and reduce the allergy risk. And so just like to thank the collaborating teams here from really Adelaide here, and from Perth, Telephone Institute for Child Health, Susan Prescott and the team there, but also our German collaborators from Harold Rentz and the team over there who are helping us with all the epigenetic work. Thank you very much for your attention.
Thanks, Tony. You can stop your share screen. Anyone for questions, please put them into the Q&A section at the bottom of your screen. While I'm waiting for a question to come through, Tony, the initial thing that you mentioned, allergy is clearly on the increase. What's the understanding of why that's happening?
Well, I just think there's a change in environment, and that's what's giving rise. I think this is all happening very early on. And from my point of view, PKC zeta is an important factor, and so far we haven't been able to disprove with all of our experimentation and it is amenable to fluctuations in levels very early on in that period. And the levels at that period are the regulating. It's the regulating period, not later on. And we think that's why later on it's difficult to change the T helper 1, T helper 2 reaction. I really think it sort of almost goes back to the hygiene hypothesis and sort of a variation of the hygiene hypothesis, because they're mainly talking about infectious diseases. Here we're talking about nutrients that are creating changes to the environment.
Okay, well, thank you. Well, we don't appear to have any more questions, but I'm sure Tony is available for any questions for anyone watching this at another time. So I'll move on to the next speaker, who happens to be me, and I'll just share my screen. I'll be talking in this short talk, shorter, faster, summary of activities and key capabilities of our group regarding lung gene medicines for CF and more, animal models, delivery, and knowing if treatment works. And I will put that on to the next one. My disclosure here is that I own shares in the company that is known as 4D Medical, that we're working with on some of the imaging I'll talk about shortly. The CF Airway Research Group, CFARG, and the Rexel, the Respiratory X-ray Imaging Laboratory, are interested in cystic fibrosis primarily, but also lung functioning more generally. We utilise a lot of animal models to ask and answer questions about those things. In cystic fibrosis, long-lasting treatments for those who are born with it are essential, and we believe a lentivirus-based gene replacement therapy could do this best by incorporation of gene correction into stem cells in the airway. Through evolution, lungs are actually designed to block airway-based treatments, and so we're looking also at methods to improve vector delivery despite those blocks. And really, treatment success should be seen as improved or stabilised lung functioning. And there's no good ways to do that, despite there being spirometry and other lung function methods out there forever. They're really very primitive in getting detail from the lung. And that's where the respiratory X-ray imaging team come in. Our primary expertise streams are in animal models, in the small ones in the lab, the rats, mice, and ferrets, and also in larger animals, sheep, pigs, and also non-human primates. We produce lentivirus vectors for development and application, and we've got an interest in improving that airway delivery through chemical and physical means. And as I've mentioned, the respiratory X-ray imaging already. We're based as a laboratory at the Alan Scott CF Research Laboratory in the Children's Hospital, Gilbert Building, and it's a PC2 facility. It has all of the usual things you'd need for lentiviral gene vector production, and also substantial computing resources for visualization of imagery that we get from the lung. We have produced 2 rat models with CF, and we're currently breeding and using them. These are rats that have CFTR defects, that's the gene that is defective in CF, that are the 508 variant, which is the one that's present in 90% of people with CF, and also the knockout, which is present in about the last 10%. These CF rats have a lot of features that are very similar to human CF disease. Unfortunately, like all the rodent models so far, the lungs don't spontaneously take up disease. However, we do know that the gene defects are present in the lung, and that's part of what we're working on at the moment. The gene delivery enhancement in vivo, we've focused ourselves on airway surface preparation, preparing the space to be permissive for the vector. And surface active agent, one called lysophosphatidyl-choline, a component of lung surfactant, has been used, and you can see a pre-treatment effect here. The little blue areas are the presence of laxed gene transfer reporter gene. You can see if you just put lentivirus into a rat trachea by itself, you don't get very much gene transfer. More recently, the controlled airway surface perturbation that we do bronchoscopically has made an extraordinary difference in the amount of gene transfer that can be delivered in vivo. And we do that with, where'd that go? Using repurposed bronchoscopic devices. And this is a small wire basket that's used for grabbing stones in salivary glands. And we now use this in a gentle wire exterior that can be extruded to essentially stroke the airway and alter the barrier. We're interested, of course, in lung infection models, both Pseudomonas and non-tuberculous mycobacteria. Both of these are important in cystic fibrosis lung disease. The Pseudomonas tends to be a long-term problem. The non-tuberculous, in most people, the non-tuberculous mycobacteria is less common, but it's extremely difficult to treat. So we can produce these bacteria enmeshed in agar beads that then lodge in the lung when they've been delivered through the bronchoscope and produce persisting airway problems of infection. This is at 7 days, but we can do that out to 14 days without any problem. We are experts in traditional small animal lung function. This is using the sort of world standard at the moment, the Flex event, shown here in the background there. You can look at all of these types of lung disease, including the infectious diseases that are important in CF. The problem is they're terminal studies. They can use a lot of animals, and we're always trying to reduce our experimental animal use. Part of that is now being achieved by using X-ray velocimetry. This is the 4D medical technology that we're collaborating on. What it does, different to anything else in the imaging sphere, is it tracks lung motion, not structure particularly, but motion, to derive detailed 3D airflow. And shown here is just a schematic of air in, air comes out, a number of imaging events over the breath, and it's through the whole breath, not just at the start and the end of the breath as CT does. This is an example of some of the images, and it produces a vector map in 3 dimensions. You're only seeing 2 dimensions here of where the airflow is at each point in the breath. And when you know lung movement, you know lung airflow because the lungs move to take the air in and out. And so that helps you look at lung health and disease. Work is now being done here in Adelaide at the National Imaging Facility at Samaree Pearl at Gillers Plains. The 4D medical Prometheum, this beast here, is the one used for small animal X-ray velocimetry. We use it, as I said, for CF lung disease gene therapy, for the lung infection assessments on lung health, and also treatment outcomes, particularly does a gene therapy work, does a CF modulator drug work. We're already collaborating with a number of other groups interstate and locally across CF modulator drugs, MPS, and fluid-induced lung injury. A little bit of data I'm going to show you is just a sample of one of the report, or 2 of the reports, comparing a wild-type rat and a knockout rat. And you can see that the reports, and essentially from the information gathered, can show you where the airflows are distributed, correctly or incorrectly. They provide data summaries. For example, here is a ventilation frequency distribution that clearly shows the difference between a normal spread of ventilation in a lung and a lung in the CF knockout animal that has a preponderance of low ventilation areas, as you'd expect. And of course, then the metrics are there to look at too. For large animals, we have a large MRFF Frontiers project running at the moment in collaboration with 4D Medical, who are producing the technology, and Samaree, who are assisting us with all of the animal work out at Gillers Plains. We're basically there to provide the evidence of the capability and the validation of the emerging human design designed for humans, but using large animals. And for example, something like this has been altered to allow animal use by lying them down, but it's essentially the same systems. And similarly, we're collaborating already using these large animal systems in regard to asthma, acute respiratory distress syndrome, endobronchial valves for emphysema, and there are others in planning. And again, that's local as well as interstate. The important thing, of course, is clinical translation. And XV clinical translation is underway. It's in use in adults in clinical trials in Australia and primarily in the USA at the moment. And it's also available for ordering in Australia through the IMED Radiology Network. We've recently, we have had ethical approval for a feasibility study of this in children, both with CF and non-CF, because really where we see this technology going is in the prevention sphere, to be able to ultimately be able to say soon after birth in children with CF, do they have airflow that's a problem, that's showing evidence of infection, and can we then go in and treat quickly? But first we have to move down into the paediatric sphere. And so we have a small study that will utilize existing fluoroscopy equipment, as is used for the adult studies at the moment. And you can see an example here. Very low dose radiation to get such a large amount of detail on lung functioning, and recruiting is actually beginning quite shortly. And finally, high magnification X-ray imaging is another stream of our interest in airway and lung health. And it's one that's designed to look at the airway surfaces. And that's done at the Japanese Spring 8 synchrotron facility over near Osaka. And one example from this is some recent studies where we used externally placed magnets outside the neck of the rat. The head is to the left, tail to the right. The other side of this airway surface is down here. And what you can see here is cartilage on either side, and these very fine strings of magnetic nanoparticles have lined up under the influence of the magnet. And to show you a nice little cool video, this is a situation where we've taken those magnetic particle strings and used an array of magnets moving outside to essentially translate and rotate things across the airway surface. And this is something we're now thinking about for assisting in delivery of pharmaceuticals and for gene therapies. So in summary, CFARG and Rexel can provide a range of animal model capabilities. We're expert in gene vectors, particularly lentivirus, but also nanoparticle, cell therapy, and other treatment agents. We've got an immediate interest and a very strong one in how does lung airflow change with treatment using the XV imaging I've just noted, as well as traditional methods for comparison. And it's obviously applicable to other lung diseases and diagnostics. Many diseases have a lung component, and if you're interested in utilizing any of our methods and techniques and capability, please give us a call. And here we are as a team on the left after an annual research review, and then inside the lead-lined hutch at the synchrotron. Thanks very much. And I shall end the show. And we're finished. So we're at the end here. We're a little over time. My apologies for that. We've got nothing on Q&A. Does Antonio, do you have any questions? Otherwise, we'll finish the session. No? Okay, well, let me finish just by saying, if you have any feedback about the session or presentation, they can be entered in the Q&A function now for a little while, or you can contact the ABMC via their website. The next presentation, time and date to be sent to everyone, as usual, on next Tuesday, is on medical devices, funding and design. And this is with presentations by Andrew Rogers and Stephen Blakeney, with the chair by Yvette van Viernam. So at that point, I think I'll say thank you very much for your attendance, and see you next time.